Dean Russell on A&E.
Thank you, Chair. My question's really around the learnings from the past few months. I've been volunteering at the local hospital, and I see how quiet some of the wards are because of the COVID crisis, and in particular A&E, seeing it with one person in sometimes, or even empty, has been quite an unusual sight. And I just wonder, what are the sort of 2 or 3 key lessons from this? One of which I'm sure must be about the fact that actually some people perhaps were using A&E previously as a sort of a 24/7 GP surgery rather than perhaps going to the GP first. So I'm just keen to get where do we go from this really moving forward?
So A&E departments have been quieter. They've seemed quiet because they've had enough space, they've had enough staff, and they haven't had so many patients. So that sounds like a service that is functioning properly. I think this idea that we've all been sitting around not doing very much is not true. We had a huge surge of COVID patients that we had to deal with. Then we've had a drop-off, but we maintained a lot of our deployed staff, redeployed staff, which has meant that we've been able to provide an extremely timely service to the patients who have appeared. So if you have departments that are big enough, you have a big enough workforce, and you're not overwhelmed by patients, you can provide a very good standard of care. So that's one thing we've learned. Possibly a lot of us knew that already. So the second thing we've learned is that multidisciplinary working has been transformational. We've been able to get teams working together. We've managed to unlock conversations and pathways that have been hideously difficult to get agreement on because we've just had to do it. So the need of the COVID pandemic to make sure that patients are kept safe has made it's been possible to break down those barriers. And it's really important that the resetting that goes forward and the real difficulties that other specialties will have with getting their services back up and running doesn't mean that we go back to silo working. So the demise of silo working has been one of the most positive things that has come out of this. And although training has suffered, we've actually managed to deliver a lot of training. We've actually managed to do an awful lot of teaching, and we've embraced, Zoom as a way of doing meetings. I've had more staff and multidisciplinary staff at my mortality and morbidity meetings than I've ever had pre-COVID, because people could Zoom into meetings because that's the way we did it, rather than expecting people to turn up in a single place. So understanding that doctors and nurses and other staff can actually usefully do things from home. We can trust them to do things from home and take part in service development, audit, all those other things, but they don't necessarily physically need to be in the hospital. Has been revelationary, in fact, and we've got an awful lot of good work out of that.
Thank you.
And can I ask? Oh, sorry.
No, go for it, Dean. Last one, please.
Yeah, just a really quick follow-up question, just on the communication side of things. Do you think that there's been an awareness? I'm aware that there's patients who should be going to A&E, especially with stroke and heart attacks and so on. But do you think there's a communications piece moving forward to get people to go to places other than A&E when they perhaps don't need to?
Yeah, so as I said, it's really complicated about getting the balance right, because we need the emergency cases to come back to us. But yes, I think the public it's quite clear, in fact, the public are thinking hard about where they're going to get care. The problem is that some of the patients who really do need to come to us are not coming. But what we absolutely, sadly, we've seen people presenting intoxicated going back up. We're seeing people intoxicated in drugs and alcohol going back up. The things that actually, we've seen a 60% decrease in alcohol presentations. It's possibly not the patient group that we're keenest to see back. I want to see the person who is having a stroke or having a heart attack. So it's trying to work out, how do we have a really mature conversation with the public about public health matters, when to come and what the other alternatives are. But we mustn't let them down with there not being good alternatives when people have anxieties about their health.
Thank you.